Thank you. So first of all, thank you for the opportunity to present today. I'll be presenting today the results of a multi-country facility costing study that CHAI conducted in collaboration with the governments of Rwanda, Malawi, South Africa, Zambia, and Ethiopia, together with the Center for Global Development and with support from the Bill and Melinda Gates Foundation. I'm really excited to be able to present, these findings today because we think they have some potentially exciting implications for the treatment as prevention agenda. I'll start by just going quickly through our methodology and then focus most of the time on findings and potential areas of opportunity. So as I mentioned, we worked together with the governments, 5 governments mentioned previously, to conduct a facility costing study across 161 treatment facilities in the 5 countries. Thus far, we've completed a preliminary descriptive analysis, and ongoing analysis is ongoing to better understand the determinants of cost and retention, and we'll have those results available in the coming months. The main purpose of the study was to quantify the cost of treatment, to understand how cost varies across countries, funding streams, administrator facility types, et cetera, to better understand the drivers of variability, and then to begin to identify potential opportunities to improve the efficiency and effectiveness of spending. The study and the findings that I'll walk you through in a moment provide a top-down assessment of facility-based costs across a random sample of sites. The study collected data quite recently in most countries data from 2010. Importantly, the study was conducted at the facility level, so it includes only the facility-based cost of treatment. It does not attempt to quantify the costs of treatment incurred above the facility or in the community level, and that will be important to remember as we move forward. The costing approach was top-down, so we started by quantifying the total costs incurred at a given facility, allocating that out to ART, and then dividing by the total number of patient years. We did attempt to collect some very basic outcome indicators by conducting a chart review of 100 randomly selected charts at each facility, and I'll walk you through some of those findings as well. On a high level, the basic findings are as you see here. The facility level costs of treatment in low and lower middle income countries are much lower than previously estimated. As you can see, ranging from $136 per patient per year in Malawi to $278 per patient per year in Zambia. And again, these are all-in costs. These include the cost of ARVs, labs, personnel, et cetera, and I'll walk you through that in a minute. Facilities in the sample have demonstrated an ability to keep patients alive and on treatment. There is significant variation in that across the sites in the sample, but again, they have demonstrated the ability to do that at these cost levels. Given the cost levels observed in this study, there are 3 important things that we wanted to highlight today. The first is that there actually don't appear to be significant opportunities to lower the facility-based costs of treatment. We'd gone into this, I think, hoping that there would be, because we sort of know how to do that, how to optimize costs, but unfortunately, given the low cost levels observed, there don't appear to be those opportunities, and I'll walk you through that. There are, however, potential opportunities to improve patient outcomes, and given the low cost levels observed, these should be affordable, and again, I'll walk you through some examples of that. And then finally, given the low cost levels observed here, aggressive scale-up should be possible. So this chart just walks you through the basic costs and the variation in costs that were observed. Again, costs range from $136 per patient per year in Malawi up to $682 in South Africa. Obviously, the costs in South Africa are higher, as one would expect, due to higher input costs, salary costs, as well as more robust testing regimens. This chart just breaks down the various cost components for you. ARVs continue to represent about 50% of total costs. Again, total costs being total costs at the facility level. And ARVs and personnel together dominate costs, accounting for about 70% of total cost. And I'll walk you through some of the details of that in a minute. I did want to point out that the lab costs observed in this study are remarkably low. There's often a lot of talk when you sit in meetings about driving treatment optimization, about the need to lower spending on testing levels. But in fact, lab spending is already incredibly low, and that's because testing levels are low. The testing levels observed in this study were for CD4, for example, in the 1.2 to 1.5 tests per patient per year range. Not surprisingly, ARV cost is primarily driven at this point by regimen cost. As we know, and there's often a lot of discussion about the fact that costs will increase as countries move away from D4T, but we do want to highlight that the impact of that cost will be minimized by expected ARV price declines. So the graphic on the left-hand side, on the top left-hand side, just illustrates the point that costs are driven by regimen choice. You can see both the average first-line cost per patient per year in each country and the regimen distribution. The chart right below that shows some projections of where we expect the market is going in terms of regimen split for first-line ARV costs. But then the chart at the left shows you, again, what we believe will be the impact of expected price declines on the average ARV cost over time. So again, the overall message here is costs will absolutely increase as patients move away from D4T, but the increases won't be as dramatic as is sometimes believed. Personnel costs, again, were the second largest cost category observed in the study, but personnel costs were also low. And those costs were driven, with variation in those costs, were driven primarily by variation in staff level and staff mix within any given country, obviously driven by differences in salaries across countries. So again, the chart at the top left-hand side just give you a sense that overall costs, personnel costs, are relatively low. The chart on the right-hand side then shows you that staffing level and mix drive personnel cost. I think the legend somehow fell off of that chart, but the line represents costs, the total cost of personnel, and the bars there show you the staffing levels observed across sites. We've used Ethiopia here as an example, but the story is consistent across all of the studies in the sample. Across all of the countries in the sample. I also wanted to point out here at the bottom, though, that the utilization levels observed in the study were also extraordinarily low. And again, I've used Ethiopia here by way of example, but again, outside of Malawi, the trend is similar. It's important, obviously, because it suggests that at existing facilities, there is still capacity to scale, and also that costs won't increase dramatically, at least at existing facilities, as we scale. As I mentioned, the study has a relatively limited ability to say a whole lot about patient outcomes. It was not a cohort study. We didn't follow patients over time. We did, however, do a chart review of 50 new and 50 established patients at each facility that we visited. And this just shows you the basic results that we saw. The chart at the top shows you attrition rates across countries, average attrition rates across the sites in the sample in each country. They range from 2% in Rwanda up to 8% in South Africa. They're significantly lower on average than we expected. And again, particularly in Rwanda, we've seen a tremendous ability to keep and retain, to keep patients alive and on treatment. And again, that's for established patients. The chart at the bottom shows you average retention at 12 months for the new patients in the sample. Those retention rates are obviously not unexpectedly significantly lower, but again, higher, I think, than we had expected to see. And again, I think the main takeaway for us here is Rwanda really stands out for their ability to manage both newly initiated and established patients. And in the next phase of analysis, it'll be really important to understand how they've been able to do that. So what does it all mean? And again, as I mentioned at the outset, given the low cost of treatment, we don't believe that there are significant savings opportunities to be had in low and lower middle income countries. There's a different story in South Africa, which I'll talk you through in a minute. So this slide just walks you through some very admittedly oversimplified math, but what it suggests is that if you take the average non-ARV costs observed across all low and lower middle income countries in the sample, and you assume that there is tremendous inefficiency in the system, which there might be. There is absolutely variation in cost observed across the sample. But if you assume that you can get rid of that inefficiency entirely and reduce the average cost to the 25th percentile of costs, you still, given the low cost levels, only see $19 worth of savings per patient per year. And when you multiply that then over expected volumes at universal access, across all low and lower middle income countries in the world, you still only see $190 million of savings in aggregate. So again, when you think about what would be required in terms of investment of time and effort to achieve those savings, it doesn't seem like this should be our primary focus. That isn't to say that there might not be other reasons to pursue these efficiency opportunities, be they, there are other impediments to access, human resource restraints, et cetera, but savings doesn't appear to be one of the reasons to pursue them. The story in South Africa is different. If you do the same math, given the higher cost base, you do see a significant savings opportunity, and that number obviously represents opportunity in just one country. The government there has identified a number of concrete opportunities that they plan to pursue in the coming years to try to reduce their costs. Again, as I mentioned at the outset, while there don't appear to be significant savings opportunities, there do appear to be opportunities to improve patient outcomes without substantially increasing costs, and we believe that these should be prioritized. The graphic at the left just shows you the trend observed in retention rate by sort of tranche of of patients initiating at different CD4 levels. The trend, very simplistic analysis, but the trend backs up the evidence that many people have walked through here today, linking late initiation to poorer retention and outcomes. What was most sort of stark to us in this study is that despite the fact that we're spending an average of $92 per patient per year pre-ART, a quarter of facilities in the sample are initiating at CD4 counts below 100, and only 27% are initiating at CD4 counts above 200. So again, despite the investment that we're already making in pre-ART programs, we're not seeing the benefits of that investment, and while that's troubling, it also presents an opportunity to really get more out of the investment that we're already making. There are other opportunities to improve outcomes at what we believe will be a low marginal cost, and this Coachram example is just one that seems like low-hanging fruit. The last thing that I wanted to highlight is that given these low cost levels, aggressive scale-up should be possible. What this chart shows you is that in low and lower middle income countries today, if you extrapolate these cost levels across all low and lower middle income countries, we're spending under $1 billion at the facility level on treatment. Now these don't include many important cost components. They don't include the above facility costs of treatment. They don't include community level costs of treatment. Nonetheless, they do suggest that aggressive scale up should be possible. They also suggest that we do need to focus in some of the areas that John Blanford highlighted earlier today on optimizing the non-facility based costs of treatment, and also on better targeting non-treatment spending. So thank you very much. That's it.